the topic has given to me for today is what are the challenges in the management of invasive fungal infections, and I will try to talk mostly on the what are the clinical challenges we are getting in the management of these IFIs. So why these invasive fungal infections are rising in India? There are a lot of reasons, especially post-COVID. There's a sudden rise of the all the fungal infections that include lot of causes, but overuse of the steroid is one of the cause that lead to the mucormycosis outbreaks in India. Definitely, the broad spectrum use of antibiotic in the ICU lead to selection of the these fungi, then lead to the IFIs. Poor infection control, and there are the reports that the high rate of fungal spores are present in the air of the hospital, especially in the lower middle income countries. They are lead to the increasing, ever increasing rise of the cases of these invasive fungal infections in India. If we see the burden of invasive fungal infection in India, this is latest reviews published in the 2023, and if you see, the India is always in the top in most of the invasive fungal infections. In candidemia, in chronic pulmonary aspergillosis, as well as the mucormycosis, India is on the top, and these infections are ever rising in India. So, what are the challenges faced by mainly by the clinician during the management of these infections? So, challenges could be non-specific clinical features of IFI, like in the aspergillosis. Mostly patients are presented with either acute or chronic respiratory symptoms. They can be mimicked, very commonly mimicked with tuberculosis, and India is a high tuberculosis burden country, and it is difficult to differentiate between these infections. Definitely, there's a lack of expert mycology laboratory facilities, and hardly one or two facilities over a district, sorry, over a state that can actually work on the mycology laboratories. Lack of the expertise in ordering and interpreting the biomarkers. With the availability of newer and newer biomarkers, every clinician are used to send these biomarkers, and without interpreting their results, they are using more and more antifungals that further jeopardize the appropriate use of the antifungals. And there's a lack of expertise in antifungals. Like if we see in most of the clinicians, the antifungal is equal to fluconazole, or there's a lack of awareness of different of fungal species that can have different antifungal have their actions. So there are a lot of challenges, but I will try to focus in next 20 minutes on mainly two infection. One is aspergillus and second is candida, because with this time we can able to do this. So how to overcome these management of the these challenges? So for the clinician, I can say, if a clinician is focused on the host factors when you are in a suspicion of invasive fungal infection, I think 50% of the problem can be resolved. So we try to focus on the host factor, and especially I will talk regarding aspergillus and candida. So we'll start with the aspergillosis. So as aspergillosis can cause three type of disease. It could be chronic, it could be allergic, or it could be acute or invasive form of the aspergillosis. So a same organism can produce any type of the disease. So it totally depends on the host factor, that which type of the disease is caused by this fungus. So if we try to look on this diagram, and it is a very good diagram to understanding this. This is shows the immune status of the host, and this is shows the frequencies of the disease. So we can see patients with immunodeficiency, there's a risk of acute invasive or sometimes subacute invasive aspergillosis. However, patients with the normal immunity or patients not having any underlying immunodeficiencies, there is a higher risk to become chronic pulmonary aspergillosis. It could be simple aspergilloma or cavitatory or fibrosing variant of the disease. Or if patient having immune overactivity for the aspergillosis, they lead to the allergic bronchopulmonary aspergillosis or allergic sinusitis or severe asthma with fungal sensitization. So I want to say that when you are suspecting the aspergillosis, always look first the host factor. If host having immunodeficiency, try to investigate on the line of invasive aspergillosis, or if patients having hyperimmune status like higher eosinophilia, higher IgE level, try to investigate on the line of allergic bronchopulmonary aspergillosis. And in patients with the normal immunity, try to investigate on the line of chronic pulmonary aspergillosis. So we'll understand one by one. So for the invasive aspergillosis, EORTC and MSGRC has given an excellent criteria for the diagnosis. If you see these criteria, they divided the aspergillosis in three parts. It could be proven, it could be probable, or it could be possible. Mostly in the clinical practice, we are looking probable or possible type, and both are depends. Patients should satisfy some predefined host criteria, some clinical conditions, and some microbiological test to come for the diagnosis of probable invasive aspergillosis. However, if there's an invasion is seen in the histopathological specimen, or there's a positive culture from a sterile site like the CSF, it could be a case of proven invasive aspergillosis. But culture positivity is very low, and mostly we are rely on these criteria for diagnosis of invasive aspergillosis. So we'll go one by one with the host criteria. As I said, very important to understand, if a patient presented with an acute history of fever, cough, and you are getting a call from a hemato-oncology ward or a patient with a transplant unit, always suspect aspergillosis. So in EORTC 2020 criteria, they said patients with neutropenia, with transplant, it could be hematogenous hematological transplant, or it could be solid organ transplant. Patients receive more than 3 weeks of corticosteroid therapy, or patients on Bruton tyrosine kinase inhibitors like ibrutinib. These patients are very high risk for the development of invasive aspergillosis. So if any patients having the symptom of fever, cough, or you are suspecting pulmonary or CNS disease, always suspect invasive aspergillosis. If you are suspecting the pulmonary aspergillosis, invasive pulmonary, you have to have some clinical criteria, and these clinical criteria are basically the CT findings. If patient having halo or reverse halo sign in the CT, you with predefined host factor, yes, you should suspect invasive pulmonary aspergillosis. Invasive pulmonary aspergillosis could be angioinvasive or could be airway invasive. Angioinvasive is the most severe form that lead to the infarct and ultimately form the necrosis that present like a halo or reverse halo sign. However, in airway invasive, the CT finding could be centrilobular nodule, thin bud pattern, patchy peribronchial consolidation, and cavitations. I think it is very common. It is not an uncommon situation to get these type of finding in a patient with the respiratory symptom. So if patient is satisfying the host criteria and the clinical criteria, we should investigate the patients for the microbiological or mycological criteria. So according to criteria, if patients having positive direct microscopy from the sputum, bowel, or bronchial bus, yes, now patient is satisfying case of probable invasive aspergillosis. If this is not present, we can send the galactomannan, or galactomannan is very good test. Basis is a biomarker, and it is a component of the fungal cell wall. Or if galactomannan level is rise, is an indicator of dividation of the fungal, or we can say an active disease. So these guideline has given the cutoff of 1 ODI for the serum, bowel, as well as the CSF galactomannan according to the clinical suspicion of either pulmonary or CNS aspergillosis. If we are not able to get galactomannan positive, we can use the PCR, but you should have at least 2 PCR positive, because aspergillus is quite ubiquitous fungus and contamination is very common. So galactomannan is more important than the PCR, and you have to have 2 PCR positivity report before saying that yes, it can cause disease. So a patient is satisfying is all 3 criteria. So patient should be treated as probable, or a patient is not satisfying the microbiological or mycological criteria but satisfying the host as well as the pulmonary criteria, yes, you can treat the patient with the diagnosis of possible invasive pulmonary aspergillosis. However, these criteria is mostly present in the patients with the hematology or patients with the in the oncology units. But in the medical ward, we have seen, and there are published data, some non-neutropenic risk factors also present for invasive aspergillosis. That could be diabetes, COPD, it could be CLD, surgery, rheumatoid arthritis, patients on long-term steroids, or patients with history of ABPA, asthma, burn. They can have risk, but so they are not very much defined. However, we have done a very good study, and our one of the senior resident from the infectious disease had done evaluation of the risk factors and role of galactomannan for diagnosis of these invasive aspergillosis in non-neutropenic patients, because we are getting more and more non-neutropenic invasive aspergillosis. And what she find, along with these risk factors which I have shown, presence of fungal sinusitis, steroid use, COVID-19, previous hospitalization, use of broad spectrum antibiotics, and uncontrolled diabetes are significantly associated with the risk of invasive aspergillosis. These patients are mostly present in the medical ward or sometime in the ICU. And what else we found, the clinical utility of the serum galactomannan level. And we found that BAL galactomannan is very good sensitivity. I think there is some.
It was mixed, and after that I made stock solutions of 1 month.
Hello.
By using this formula, she understood that she has to
Dr.
take 20
Harman,
mg
please
of the
unmute
powder
yourself.
in 20 ml of water to make a concentration of
Dr.
1000 microgram per
Harman,
ml.
please unmute yourself. Yeah, thank you.
Yeah. So what also found the clinical utility of galactomannan, what we found, yes, in the BAL for the diagnosis of invasive aspergillosis in non-neutropenic patient, and CSF for diagnosis of CNS aspergillosis found to be very good sensitive. However, serum galactomannan is not in a very good test, and it's very low sensitivity for the diagnosis of invasive aspergillosis. Yes, so we can use BAL or CSF galactomannan even in the non-neutropenic patients for the diagnosis of invasive aspergillosis. So it is about the invasive. Now for the chronic pulmonary aspergillosis, so we have discussed one thing. Second is chronic pulmonary aspergillosis. Here we have to have some other host criteria about the same organism that can cause disease. For patients if presented with a 3-month history of fever, plus minus fever, cough, and hemoptysis and weight loss, and there is a past history of either pulmonary tuberculosis or tubercular cavity, and patients already receive once, twice, sometimes 3 times of anti-tubercular treatment and not improve, yes, you should suspect chronic pulmonary aspergillosis, and it could be present in form of aspergilloma or cavitatory pulmonary aspergillosis or fibrosing pulmonary aspergillosis. So in short, I can show this flow diagram for diagnosis of chronic pulmonary aspergillosis. If any patient presented with a long history with fever, cough, hemoptysis, and weight loss, and already taken the treatment of TB, all attempts should be done to rule out multi-drug resistant tuberculosis. If we did not find or do not find any multi-drug resistant tuberculosis, we should send Aspergillus IgG level, means patient having good immune system. That implies a positive IgG level. Or if IgG level is positive, we can say it is a case of chronic pulmonary aspergillosis, and patient can be treated with the itraconazole. If IgG is negative and still you have high suspicion of the chronic pulmonary aspergillosis and you have ruled out the tuberculosis, now we can send BAL galactomannan, but not serum galactomannan. If BAL galactomannan is increased, then we can say yes, it is again a case of chronic pulmonary aspergillosis. But if it is negative, then we have to rule out other diagnosis. So here the important host factor is a 2 to 3 month history of fever, cough, sputum, hemoptysis, and we can this is very easily mimicked with the tuberculosis, and patient receive multiple courses of anti-tubercular treatment. Second, I come with the invasive candida infection. Candida can cause lot of invasive infection in the form of candidemia, intraabdominal infection, UTI, endocarditis, CNS infection, joint infection, or sometimes chronic disseminated candidiasis. So I'll try to discuss mostly the candidemia and intra-abdominal invasive candidiasis, because these are the most common. We are seeing these cases in the ICU or sometime in the surgical wards. So again, as I said, we are need to be understand what are the risk factor for invasive candidiasis, in which case and we should suspect and we should send or we should treat. So if we discuss the general risk factor, colonization with the candida species, diabetes, GI perforation, increased age, pancreatitis, and sepsis. These are the common risk factors, as Candida is a common colonizer of the skin. And if uh, if there's a breach in the skin or GI mucosa, it can easily goes into blood and can lead to the candidiasis. So when you are in suspicion of candidiasis, colonization is very, very important to look, especially in patients in the ICU setting. Other heterogenic risk factor, patients on long-term hemodialysis, patients on broad spectrum antibiotic that lead to the selection of the candida, patients with the central venous catheter, CRBSI, patients on corticosteroid or immunosuppression therapy, GI surgery. Again, how you mark GI surgery is very, very important. As I said, it is in common cells of the skin as well as GI mucosa. There's a breach of the GI mucosa. There's a high risk of transmission in the abdomen that can lead to the invasive abdominal candidiasis, or patient on long-term hospital stay, mechanical ventilation, or total parenteral nutrition. Along with this, patients with a transplant, yes, like the aspergillosis, we should suspect candidiasis. So if we understand the pathogenesis, it is a common mucosal colonizer in the oropharynx, upper lower GI tract, genital tract, and urinary tract. And if there is a presence of risk factor or host factor like multiple antibiotic, vascular access, like CVC, parenteral nutrition, ICU stay for more than 7 days, presence of candida colonization, or patients with major abdominal surgery that lead to the breach of the mucosa and enter this candida into the blood and lead to the candidemia, and further it can be spreaded to the eye, lead to the endophthalmitis, endocarditis, catheter related abscess, CNS infection, and hepatosplenic involvement. So it is very important to look fundus examination in every patient in which you are suspecting the candida. It is very, very important, because endophthalmitis is one of the complication, or sometimes you can pick or you can suspect early candida if there's any sign of endophthalmitis on fundus examination. So what are the role of various score and biomarkers for diagnosis as well as the treatment of these candida infection in ICU? So the most commonly used biomarker for candida is beta-D-glucan, or basically it is a pan-fungal marker, and it increase in various fungal infection, including histoplasma and others, even PCP also. But when you are suspecting candida, if beta-D-glucan is increased, in most of the ICU we are giving the antifungal drug, or sometimes we can use some candida colonization index and candida score. So there are a lot of literature has been published regarding the use of beta-D-glucan or various score, but none of the found to be a gold standard to early selection of the this antifungal or echinocandins therapy when you are in suspicion of the candida. A very good trial is published in the JAMA in 2016. It is Empiricus trial, and they have given this micafungin in patients admitted in ICU with septicemia, with positive candida colonization and multi-organ dysfunction, and try to see is there any role of empirical adding of this antifungal drug if patient is satisfying high candida score or colonization. But they did not find any beneficial effect of early adding of the micafungin in ICU, or there's no difference in the motility, as well as the no difference on the culture positivity, candida score, candida colonization, and everything, and as well as the survival. So again, there's always dilemma when to select early anti-candidal therapy when you are in high suspicion of the candidiasis. So I searched the literature and I could find two important flow chart which can be used in the clinical setting to selection when patient is at risk of invasive candidiasis, and we have already discussed intrinsic as well as the extrinsic risk factor. And I think if patient is having more than 3, 4, 5 risk factors, we should try to search for the candidiasis. And with these risk factors, if patient having colonization index is 0.5 or corrected colonization index is 0.4, so which can be easily calculated with number of sites positive upon number of site screen, and that should be done bi-weekly. And if it patient having high candida colonization index and patient with the high candida score, it should be more than 2.5 or 5, sorry, 2.5 or 3. And along with this, patient having more than 4 or you can say 5 days of ICU stay with sepsis, with CVC, with mechanical ventilation, already on broad spectrum antibiotic and not responding. Along with this, either patient on total parental nutrition, is patient on dialysis, major surgery, very, very important, pancreatitis or immunosuppressant drug. Yes, these are the conditions in which you can early select the empirical antibiotic and empirical antifungal therapy. But try to look, patient should be satisfied most of the criteria like colonization index as well as the candida score as well as the predictive score. Or this is the one of the latestly published flow chart or guidelines or guidance from the experts from the India for use of antifungal therapy for candidemia in ICU, especially in lower middle income country. What they said, if patient is in ICU and in septicemia and you have given the appropriate antibiotic and not responding and deteriorating, and patients having multiple risk factors which we have already discussed. So very, very important, when you are get any call from the ICU for selection of antifungal drug on suspected candidemia, always try to look for multiple risk factors. If these risk factors present and they have already sent the blood culture and which grew the candida, so it is in gold standard for diagnosis, you should start immediately echinocandins or fluconazoles on the basis of type of the species and sensitivity. But in most of the time, because the blood culture positivity in the candidemia less than 50%, and when you are in doubt of abdominal invasive abdominal conditions, the positivity is around 5 to 30%. So most of the time we have culture negativity. During that time and you are still high suspicion, we can send beta D glucan, and there should be a 2 beta D glucan positive, 2 serial beta D glucan positive. Only then you should start antifungal therapy. So I can say along with the beta D glucan, you should check for the colonization, candida score as well as the predictive score for the suspicion and send the beta D glucan level. If the 2 beta D glucan level is positive, we can start. But if it is negative, again you have to look for other cause. If beta D glucan is not available, then we have to rely on this candida colonization or candida score or predictive rule, and you can start an empirical antifungal therapy. And it is very important to re-evaluate and reassess the patients in 72 hours. If there's a no clinical improvement, look for alternative cause. You can stop the antifungal. But if there's a clinical improvement, yes, you can continue. So still there's a very much dilemma regarding the use of beta D glucan directed therapy or some predictive score directed therapy. Still there's the data is coming, but there's no definitive evidence. But we can utilize this flow chart. It is very, very helpful in the clinical practice to appropriate selection of anti-candida therapy in ICU. So a take-home message for my talk is to understanding the host factor is crucial for suspicion of invasive fungal infection. That is very, very important, in which patient you should suspect Aspergillus chronic or invasive or allergic or invasive candidiasis. You should look very thoroughly to the host factor of the patients and appropriate biomarkers. Like if we are sending a galactomannan level in a patient with chronic pulmonary aspergillosis, it is no use. Galactomannan is used for the diagnosis of invasive pulmonary aspergillosis. It is not a test for diagnosis of chronic pulmonary or allergic pulmonary aspergillosis. You have to send Aspergillus IgG level for the diagnosis of chronic pulmonary aspergillosis. So appropriate sending of the test and interpreting of test is very, very important. And definitely India needs more microbiological focused laboratory and as well as training of healthcare personnel to overcome this tip of icebergs of increasing invasive fungal infections. Thank you.